everyone, my name is Minjung Cho. I'm one of the social media section editors of the Archives of Plastic Surgery. I'm excited to introduce APS Hot Off the Press. 2 times a month, we'll be hosting Hot Off the Press with one of the recently published APS authors and 2 panelists. You have a special opportunity to hear directly from the authors and join an insightful discussion between panelists. You can also leave your thoughts as a comment for further discussion.
Hello, everyone. Welcome to the APS Heart of the Press. I'm Kyori Kim, a social media section editor of the Archives of Plastic Surgery. Today's article is Algorithmic Approach to the Lymphatic Leak After Vascular Reconstruction, a Systematic Review. The authors of this article, Dr. Peter John Nicksic and Brad Foster Michelotti from University of Wisconsin Hospitals and Clinics are joining us today. And Dr. Samarth Gupta from the SMS Hospital is joining us as a panelist. He's also an APS ambassador. Let's start with Dr. Nicksic's introduction of his article.
Today, I'd like to talk to you about our study that was published in the July issue of Archives of Plastic Surgery, the Algorithmic Approach to the Lymphatic Leak After Vascular Reconstruction, a Systematic Review. To discuss some of the background information as it pertains to this study, groin lymphatic complications, which include lymphocele and lymphocutaneous fistulas or lymphatic leaks, occur as frequently as 18% of all groin vascular surgeries in the literature. Lymphatic leaks, when they do occur, increase the risk for infection, delaying wound healing, and extended hospital stay for patients. There are data to support many therapies for lymphatic leaks, but there are no consensus recommendations in the literature. The goal of this study was to create an evidence-based algorithm for the lymphatic leak patient after vascular reconstruction. To do this, we conducted a systematic review in accordance with PRISMA protocol. Our inclusion criteria were English studies reporting interventions for the management of lymphatic leak after vascular reconstruction. We excluded endovascular studies involving lymph node dissections for oncologic diagnoses and level 5 data, including case studies. Our query yielded 333 total records, and we included 8 studies for analysis. We then categorized interventions in the literature by efficacy, designating each intervention as either efficacious, mixed efficacy, or not efficacious based upon the level of evidence, the number of studies supporting each intervention, whether or not there was consensus recommendation between studies, success rate, and days to resolution reported in the literature. The 3 surgical interventions that were discovered as part of our review were lymphatic ligation, primary muscle flap, and suction drain placement. Lymphatic ligation was designated as efficacious because it had the highest level of evidence, number of studies, success rate, and the lowest days to resolution. For this reason, it was considered to be first line within the algorithm. The non-surgical interventions were conservative management, VAC therapy, and glue embolization. Conservative management consisted of bed rest, elevation, compression, and serial wound cultures to monitor for infection. Conservative management was considered first line and deemed as efficacious because it also had the highest level of evidence, number of studies, had consensus recommendation in the literature, and had a relatively high success rate and low days to resolution when compared to other non-surgical interventions. With the data from our systematic review, we then constructed this algorithm for the management of the lymphatic leak patient. Our algorithm begins with assessing the patient for an acceptable anesthetic risk. If they are not able to undergo another operation, then the first line non-surgical intervention should be used, which is a trial of conservative therapy for 3 weeks. If the lymph leak patient does not resolve in this time, then other non-surgical interventions like glue embolization can be used. If the patient is able to undergo surgery, and they possess risk factors associated with lymphatic leak, which in the literature were found to be patients undergoing aortobifemoral bypass surgery, a preoperative length of stay greater than 1 day, and redo operations of the groin. Then they should be treated with lymphatic ligation and a primary muscle flap. We decided to include a primary muscle flap to augment lymphatic ligation because sartorius flap is within the surgical field, a relatively low morbidity operation, and the study that demonstrated its efficacy listed it at 100%, despite not reporting the time to resolution. If these patients, or if the patient does not possess risk factors associated with lymphatic leak, the next step in the algorithm is assessing for synthetic graft material. If the patient does have synthetic graft material, they're at higher risk for infection with biofilm formation and loss of the vascular reconstruction. So we would recommend lymphatic ligation with primary muscle flap for those patients. If they do not have either risk factors associated with lymphatic leak or synthetic graft material, then a trial of conservative therapy may be appropriate. If after 3 weeks this does fail, then we would recommend they be treated surgically with lymphatic ligation with primary muscle flap. Conclusions from this study include that early operative intervention with primary muscle flap reduces time to resolution when compared to conservative management. For this reason, the majority of patients in our algorithm received lymphatic ligation with primary muscle flap. Alternative interventions like glue embolization may be offered after a trial of conservative therapy is failed in patients who are not surgical candidates.
Thank you so much for your presentation. Let's move on to the discussion part. Dr. Michelotti, do you want to add anything?
Yeah, so I think that really the aim of this study was that as plastic surgeons, we were consulted for complicated wounds, and in this situation, specifically problems with groin healing, delayed healing after vascular reconstruction, the setting of lymphatic leak or lymphocyte formation. And as a plastic surgeon, when we are consulted for this, we think about muscle flaps as being kind of first line treatment for complicated groin wounds. And so we really wanted to query the literature in terms of the evidence to support muscle flaps or early intervention after problems with respect to vascular surgery of the groin. And honestly, what we found was that there weren't a lot of good data to suggest, one way or the other what to do after you have a problem with complication with respect to vascular reconstruction in the groin. And so what we did find, though, was that there are data to support muscle flaps and even prophylactic muscle flaps. And as plastic surgeons, this is important so that we can educate our vascular colleagues with respect to risk factors that would then lead potentially to a higher rate of delayed healing, lymphatic leak, et cetera, in the groin, and then perhaps counsel them that prophylactic muscle flaps in this scenario, it may be an important thing to consider, particularly when sartorius flaps are right in the operative field and are low morbidity in these vascular surgery patients. And so if we can prevent complications and then avoid the secondary operative morbidity or the cost associated with that, I think that's something important that we were kind of trying to determine from the systematic review, although the evidence was lacking. There are good data from the University of Pennsylvania, Dr. John Fisher and others who have looked at risk factors for complications after vascular surgery in the groin and kind of identified and did a risk assessment score to determine whether or not prophylactic muscle flaps are important or should be considered. And so we do follow that at the University of Wisconsin, and we consult our vascular colleagues and educate them about the use of prophylactic muscle flaps. But this study in particular was more about using the available evidence to develop an algorithm for treatment after lymphatic leak. And so we did find that ligation and conservative treatment were important strategies, but we prefer, and based on the evidence, although limited, it suggests that resolution of the lymphatic leak may occur more quickly with intervention with a muscle flap. And so I think we've used what we could with the available evidence to develop this algorithm and hopefully educate folks moving forward.
Thank you. I think this article is very meaningful. Like it's suggesting like evidence-based guideline for the treatment of lymphatic leak. Dr. Gupta, do you have any question to authors?
First of all, hi, and congratulations to the authors for such a wonderful study and getting an algorithm out of, there's hardly any data that is really presented in such a manner, such a great manner. So I wanted to ask, like, there are other risk factors like previously scarred sites and factors like lymphadenopathies. And basically, when there are large lymphoias and lymphovascular leaks. So what is the consensus, or like, what do you take out of the study where we can really perform, like, continue with the non-conservative management, and for how long?
So you're asking when a patient is appropriate for conservative therapy?
Factors that have not been included in the study. So, and they are important because traditionally speaking, people still do the conservative therapy first before going on to the surgical part, especially in low flow sinuses.
Sure. Based on the risk factors for the development of lymphatic leak, Dr. Michelotti mentioned the Penn groin study, and they look at risk factors like diabetes, other sorts of comorbidities, and they determine how or what the risk profile for that patient's groin would be for all complications. And then if you apply that, there's a little bit of it's not the exact question that we're trying to answer, being like, the question we're asking is, what is the chance that this patient can heal this lymphatic leak conservatively? If you apply those risk factors for lymphatic leak formation to that, then it can help guide, okay, if this patient does get infected, is there synthetic graft material that a biofilm can form on, and are we going to lose the reconstruction? So in our study, we recommended that patients without high risk factors like aortobifemoral bypass, where there's larger lymphatic vessels that are going to be transected, a non-reoperative groin, and a preoperative length of stay less than 1 day without synthetic graft material, they would be appropriate for conservative therapy. And the data supporting conservative therapy says at 2 weeks, it will be 71% successful. So if after a 2-week period without any sign of secondary infection, I think that it would be appropriate to trial conservative therapy for that length of time. And then if they are not healed, proceed with lymphatic ligation with a primary muscle flap.
Great, thank you very much. I just had a thought there's a study on VAC therapy, I guess. Were there any details on what kind of wound they were taking care of during the VAC therapy in that particular study? Was it a large infected wound, or what was it?
If I'm recalling the study correctly, the VAC therapy study just looked at lymphatic leaks, so non-secondarily infected lymphatic leaks. I think that at least practice patterns in Wisconsin would be that if a wound with lymphatic leak and there's a direct channel between the skin and the vascular reconstruction, if that wound were to get infected secondarily, everyone would be taking them to the operating room because the entire vascular reconstruction is at high risk of failure.
So I think early intervention is important. What I want to ask is, do you want to use any like diagnostic modality, or just clinical assessment is enough?
Are you talking about being able to find the leaking lymphatic vessel? Yeah. I would say that practice patterns within our division of plastic surgery, and Dr. Michelotti can talk more about this, it's like 50-50. Some of our staff use lymphatic mapping. They'll do lymphozurin just dermally injected within the dorsum of the foot, massage, and then look to see where the blue is leaking within the groin. The problem is, though, that some vasculopathic patients, they have elements of lymphedema, and that blue does not get all the way up to their groin in any appreciable, appropriate amount of time. Other ways is, and I think Dr. Michelotti does it this way, they just dry out the wound the best they can and then look for serious fluid leaking. And a lot of the times that is, we're able to find it that way and just ligate it with a clip or a silk tie.
And sometimes, we don't find the lymphatic vessel that's leaking, and we do the muscle flap and we have resolution anyway. And so I think one of the interesting things from a histology standpoint in this paper and reviewing kind of how a muscle flap works in the setting of lymphatic leak or lymphatic complication, it actually then responds by dilating the lymphatic tracts that are present within the muscle to act kind of as a sponge for shunting the lymphatic fluid into the venous system. And so principles that we apply to lymphedema as well. When we do lymphatic surgery for lymphedema in the post-cancer reconstruction patient, we bring healthy lymphatic vessels or muscle and vascularized lymph nodes into the area and expect them to work as a sponge to pump the fluid back into the venous system. And so that's not dissimilar from bringing muscle into the area. And actually, Dr. Nicksic cited a paper in this study looking at the histologic response to lymphatic leak when muscle is placed into the area. And we see that the muscle is working in our favor to shunt the fluid. So.
Okay, thank you so much, everyone, joining Hot of the Press.
Dr. Nicksic and Dr. Brett, it was amazing to have you. The paper is absolutely stunning. It's going to help us in our practice as well. So thank you very much.
Thank you, guys.
Thank you for having us.
Thank you everyone for joining us this fantastic discussion. Be sure to tune in for the other article that we'll be discussing on this month's Hot of the Press. You can also connect to Global Plastic Surgery Society through our YouTube channel, Facebook, Instagram, and Twitter. We're looking forward to meeting with you on our APS social media. See you soon.